Hey, hello, my name's Thomas. I'm in the Advanced Patient Assessment course. I'm doing my neurological video assessment. These are my role players. My dad is Lee, my stepmom Shannon, and I think there's a cat that may pop in the frame from time to time. I don't have any medical equipment on me as the college is closed, so this will just be bare bones pen and paper scenario. I will discuss in detail the equipment I would use as applicable. So in this scenario, I've been dispatched to a 26 Bravo 1 unknown caller, unknown status. Caller, the step or the wife, just said her husband's not acting right. Thinks something's going on. Good morning. My name's Tom. I'm a paramedic with local community center. What's going on today? Who's the patient? Are you the patient? Okay, sir. My name's Tom. What's yours? Lee. Lee. Okay, as soon as Lee spoke, I noticed a left-sided droop to his lips. I don't see any obvious bleeding or looking at him. I don't see any pupillary deformities at this time, but I'm already kind of getting my spider senses tingling. I would have my mythical Ghostbuster partner, EMT, is going to go ahead and start to acquire the 7 fundamental vitals, those being blood pressure, heart rate, respiratory rate, O2 saturation, blood sugar, temperature, and when we get to a good point in the assessment, I'll obtain a pain scale. Sir, first thing I need you to do, just tell me how you were doing this morning and hand me both of your hands.
I guess okay.
Okay. So why was 911 called? Ma'am, did you call 911?
I did. He is just not acting himself. He's a little disoriented and unbalanced, and that's not his normal behavior.
Okay. Has he hit his head at any point within the last 24 hours?
Not that I've seen.
Okay. All right. When was the last time you say he was acting normal?
Last night when we went to bed.
Okay, so his last known normal was 2,300 hours yesterday. That puts him outside of the tier 1 activation window if we decide this is a stroke, but he still is within my agency's tier 2 activation is 24 hours without suspicion of a bleed. Correction, 24 hours without suspicion of a bleed. Mr. Lee, can you hand me both your hands, sir? Okay, I need you to squeeze with all your might. I've got a strong right side squeeze already, picking up a little like a weak letdown on his left. Okay, close your eyes, Mr. Lee. Hold your arms right in front of you. Do your best to keep them up ahead. Okay, ready? Go. Left side droop. All right. Go ahead and put those right back down to your side. But keeping that eye closed, take your right finger and touch your nose. Any finger fine. Excellent. Put it back down. Same with your left. Having a hard time following instructions and following instructions and hitting targets with his left hand. Okay, Mr. Lee, I need you to repeat after me. You can't teach an old dog new tricks.
Can I open my eyes?
Sure can. You can't teach an old dog new tricks. Noted left side deficit again on the lip.
You can't teach the dog.
Incomplete phrasing, and he had a difficult time recalling information he just heard. Okay, my vital signs were taken. There's no standout other than hypertension. Okay, sir, do you take any medications? What medications do you take, if you remember them off the top of your head?
I take blood pressure medicine, diabetes medicine, and cholesterol medicine.
Are you insulin dependent?
No.
No. Okay. Do you have a medical list I can borrow from you, or a medication list I can borrow from you?
I think so.
Oh, thank you for having all this information prepared ahead of my arrival. He takes metoprolol, which is a beta blocker, so I'm going to expect to see reduced cardiac output, a lower blood pressure, and a lower heart rate than standard. If I see the opposite, he's either medication non-compliant or the disease process is kind of counterintuitive. The peptides I would expect interacted due to a non-CHF related hypertension episode would be my atrial natriuretic peptide and my C-type natriuretic peptide. B-type was reserved for CHF, and I do not see any evidence of that at this point. He takes hydrochlorothiazide, which is a cholesterol medication typically seen in his age and patient population in the southeast. He takes atorvastatin, which is going to be another blood pressure lowering medication, kind of helping with that vascular resistance. He takes aspirin, which is not a blood thinner. It is going to help him keep that blood flowing as best as it can, but it will not break apart active clots. And Mounjaro is a medication I would have to research, but it really isn't clinically applicable at this time. I just know that it is for diabetes. My finger stick showed me 70, sir, is 70 within your normal blood sugar range?
A little low,
A
actually.
little low for, okay. Did you have breakfast this morning? What did you have to eat?
Sausage and eggs.
Eggs, fried eggs.
Sausage and fried eggs. Sir, we'll talk about your diet on the way to the hospital, but sausage, fried eggs, and anything to drink with that?
Coffee.
So we'll talk about the need to maintain our lifestyle choices, but black coffee, sausage, and fried eggs are going to kind of mess up all those medications you're taking. But that's neither here nor there.
It was worth it.
When did it really start? When did you notice he acted abnormal, or sir, when did you start feeling weird?
I woke up.
He had a hard time getting up.
Had a hard time waking up this morning. Can you detail that, Eddie? At this point, I would have my EMT partner go ahead and acquire a 12-lead ECG.
He's not normally a morning person to begin with, but he was unusually groggy and even he was slower getting up. And then once he sat up, he had a hard time actually getting out of bed.
Okay.
His feet under him.
So I've already gotten enough information to activate a stroke criteria based on my agency's policies. But that being said, having a hard time waking up and being a prudent healthcare provider, I want to see just the extent of what's going on. So I'm going to activate Community Medic 1 to dispatch be advised. We're going to go ahead and go with a Tier 2 stroke activation, notify Wake Med Maine of a incoming stroke patient, ETA about 1 hour. Okay. So, sir, carefully, if you may, will you stand up? Use me for support or the table, whichever you feel is required. Having a hard time? I'm noticing his legs are shaking. As he tries to walk, I notice his legs are bobbling underneath him. Sir, we'll go ahead and put you right back down. Okay? I don't want to run the risk of you getting hurt. With the inability to walk steadily, I do believe there should be some posterior involvement. I forget the name of the bundle of arteries in the occipital region, but I believe that one could be infarcted as well. So if you can shake the illusion of now being in an ambulance. I'm having the wife ride with me as she's pretty much the only good caretaker or history taker right now. And when the hospital has their series of questions, she's going to be my most reliable source of information because I can't hang out with them all day. I've required a 18 gauge in the left AC. I'm going to go down from the left AC. I'm a bit of a hater, but I want to use the left forearm. I'm going to leave the right arm alone because that's when they're going to do some of their arterial interactions if they need to go in and operate on this man pretty immediately. So I'm going to go at least one 18, but typically two. Anything 20 gauge above the wrist, CT, and can get in there fine and access. I've pulled a blood panel being red, blue, green, purple colors, and so we can have accurate blood for the hospital upon our arrival. He is not sepsis criteria, but if he were, I would have taken cultures aerobic first, following by anaerobic. Now that we're in the back of the truck, I'm going to perform with that blood I've acquired. I'm going to take an emergency point of care lab test. I'm looking for things like potassium abnormalities, sodium abnormalities. I'm looking for elevated PTT and PT levels. Those may indicate clotting. Potassium in high and low levels can cause altered mental status, fatigue, and joint spasming, as well as sodium levels. Excessive salt can again cause that dehydration-like feeling. He's not complaining of that, but with the poor history and the not a lot of mention of water in his initial sample, I'm going to keep dehydration in the back of my mind. Once my sample is complete, I have no identifiable life threats other than the potential stroke. I'm going to have him puff out his cheeks. Sir, will you puff your cheeks out for me best you can? Okay, so not enough facial nerve tone in order to maintain a full puff. or a seal, as we like to call it, that also kind of makes me worrisome of an inability to maintain their own airway. I will not meaning I'm going to RSI this man where he sits, but this disease could go down a pathway where airway maintenance is a consideration, and I'm going to make that PO alert to the hospital when we arrive. Will you raise your eyebrows? He's able to raise his eyebrows. I've already been able to atone for facial movement, able to follow instructions and move his hands coordinatedly in the pre-hospital setting. I'm going to do a fine motor control test using every paramedic's best tool, the pin he took from his EMT. Sir, I need you to click this pin with that left hand if you can. He's having a hard time holding the pin. He is trying to ram it into his other arms in order to click it. I'll take that from you, sir. Same thing, right side. Sounds good. Click it 2 more times for me. Thank you. Appreciate that. Took that 12 lead in the house. I did not see any signs of stroke on the monitor. When we say stroke on the monitor, I'm typically looking for cerebral T waves or Kaiser Helm presentations in leads V5 and V6, my lateral lows, and my septal leads, including V1 and V2, but they could be present anywhere. My vitals trendings are not significant at this time. We've made our stroke activation to the local neuro center. Within that tier 2, I'm not worried about a helicopter. I'm not going to charge this man $60,000 in order to get him somewhere a little bit quicker, but he does not meet surgical intervention criteria at this point due to time. The LVO, large vessel occlusion, is kind of near with his inability to follow simple commands at this point. Sir, another question for you. What is this?
Billfold.
Okay. He elderly answered as a billfold. Okay. All right. So again, he's able to identify simple objects, but he's unable to follow simple muscular or motor skill commands. I'm going to continue to reassess this patient. Keep the ice. I would probably do another blood pool if my transport time exceeded an hour. We're right on that mark. He does have a diabetic history, but my sugar of 70 kind of ruled that out, and no trauma. So we meet all the requirements to activate a coach stroke. He sitting at rest, he didn't make any kind of weird faces or shapes, but when speaking and using those muscles, he did have some deficits in tone noted. So I'll keep that in mind and report it to the doctor. IV access is established. I don't see any cardiac intervention needed at this time. Some neurological deficits do come from the heart. The heart is an endocrine organ as well at the end of the day. But I don't see any need to kind of work this man up as if he's about to crash. If he was a little pale diaphoretic, disordered breathing, if I thought that was some diaphragmatic breathing occurring, I would place my pads anterior and posteriorly and most likely provide assistive ventilations. If this was looking like a head bleed, recent head trauma, Cushing's triad of hypertension, a high hypertension with a wide pulse pressure, a low heart rate, and disordered rate respirations, I would provide assisted ventilations at 1 breath every 3 seconds with an inspiratory volume of 500 mLs. And if you worsened from that point, I'd RSI using either VEC, ROC, or succinylcholine. We're in Southeast North Carolina. Succinylcholine is kind of a dangerous bet with any of the population due to its negative interactions with Native American ancestry, causing such big issue, most important issue for EMS to have to deal with is that malignant hyperthermia as well as some potassium channel exchanges due to that depolarization of the muscles. So I'd go with ROC at 1 mg per kg. Sir, how much do you weigh?
245.
245, which is going to be roughly 165 kilograms. So that'd be 165 milligrams of ROC, followed by ketamine for pain and sedation. Sir, how much? 165 pounds. Using my trusty dusty calculator. Using my sedation dose of ketamine would be 165 kilos times 2.0 milligrams would be 330 milligrams of ketamine, 165 of ROC, and I like to combo ketamine and fentanyl for pain relief and analgesia. Fentanyl's max dose is 100 micrograms in the pre-hospital setting based on weight at 1 mic per kilo. He exceeds the max, so we're going to cap it at 100 mics IV push fentanyl. So are you allergic to anything?
Yes.
So, sulfa drugs.
Sulfa drugs?
Hiding out here. Ants. Bugs. Some bug stings like
Wasps.
fire ants and wasps. And penicillin.
Works for me. So he is allergic to sulfa medications. We carry fentanyl citrate, so I'm really not worried about the interaction. Ketamine is not a sulfa drug, nor is rocuronium. He is allergic to hymenopteric insects. I really hope nobody in this ambulance gets stung or bit by an insect in the next period of time. Penicillin, we'll keep that in mind as an antibiotic, but most hospitals have started to rule that out due to persistent penicillin allergies. But that's pretty much all I would do and all I would be worried about prepared for in the meantime. If this patient suffered an acute seizure, which stroke victims can and typically do, I would administer 2.5 to 5 milligrams of Versed per my local protocol. For refractory seizures, I would follow up with either a repeat Versed dose at 5 mg for a max of 10, or 2 mg per kid ketamine for a max of 400 with medical control orders. Once the seizures are stopped, I would administer I think it's 1 gram Keppra over 10 minutes for a anti-epileptic response. But we will continue to monitor emergency traffic to the hospital due to stroke activation, and again, follow-up report to the local ER. Thank you. I appreciate your time, and that's about it.